I want to welcome Dr. Eric Singy from the University of Texas, MD Anderson Cancer Center, and Dr. Jenny Ha from Johns Hopkins School of Medicine. They are going to be guiding us through some really exciting information in early stage lung cancer. This is the first Hope Summit that we have added this, and you all know, you've heard me say, I've been doing this a long time, and this is, again, one of those moments for me that's just super exciting, because when I started in lung cancer, we rarely, if ever, saw early stage, and it certainly wasn't an area of research. So it's super exciting to add this session to Hope this year. Remember that you can enter your questions through Event Mobi. And a special welcome and thank you to Colette Smith, who is going to be our survivor moderator. So please enter your questions, and Colette will make sure that when we come to question and answer time, that your questions get answered. Dr. Singy and Dr. Ha, welcome.
Thank you. Well, hello, everyone. I am honored to be here to speak at the Hope Summit. Longevity does incredible things, so really excited to be here to focus on the patient aspect of what early stage lung cancer means. As I like to say, this is how we say bye to early stage lung cancer. So if you see my Instagram or TikTok, this is an ode to that. These are my disclosures. So we have a packed agenda. I really want to protect the Q&A time so then we can get all of your questions answered. But we're going to go through what is early stage resectable non-small cell lung cancer, talk about staging basics. We'll talk about why surgery alone isn't always enough for every patient. We'll talk about key treatment terms that you need to understand. What does molecular testing mean in early stage disease? How does it affect your treatment plan? What about monitoring after surgery? And then questions you should ask your team, followed by some key takeaways. So first of all, what is early stage non-small cell lung cancer? Well, as many of you know, lung cancer is one of the most common cancers in the world. Non-small cell lung cancer is the most common subtype of lung cancer. It makes up 85% of all lung cancer cases, and all you need to be at risk for lung cancer is to have lungs. Additionally, early stage, specifically for non-small cell lung cancer, it makes up about 1 out of 4 patients that are being diagnosed with lung cancer. In early stage non-small cell lung cancer, the disease is still localized, so it's in the lung and possibly the lymph nodes. And if the cancer can be safely removed with surgery, that's what we call resectable disease. At this stage, our goal for patients with early stage disease, resectable disease, is cure. So we go aggressive, we aim for cure. So talking a little bit about staging. Staging is, where is your cancer located? For stage 1 disease, that's where the tumor is only in the lung. So this is a CT scan. When we're looking at CT scans, it's flipped, right? So the left side is the right side is the left side. And imagine the patient's feet are out of the screen, and we're looking slice by slice at the body. So you can see in the red circle, that's the tumor in the right lung. For stage 2 disease, the tumor is in the lung and also some nearby lymph nodes. And for stage 3 disease, it's either a larger tumor that's in the lung or more lymph node involvement. Typically for stage 2 and stage 3 disease, we use what we call multimodality therapy. So surgery, maybe radiation, and then of course systemic drug therapies like myself, a medical oncologist, will give patients. Knowing the stage is really important, guys, to understand what the treatment plan is going to be, because it helps us choose the best treatment plan for the patient. So are medications needed either before and or after surgery? So why might a patient need more than just surgery? So even if an amazing surgeon like Dr. Ha does her surgery and removes the entire tumor, we worry about microscopic cancer cells. Microscopic cancer cells means that you can still have cells that are still very small and they can't be detected by the naked eye, and they may still remain in your body. Additionally, these cells can then grow or spread later if they're untreated. And this is where we get into historical rates of when cancer may come back, even when we're aiming for cure, even when we're being aggressive with early stage disease. So these are historical rates for cancer recurrence, cancer coming back after surgery. So for stage 1 disease, about 20 to 25% of cases. Stage 2, about 20%, and even higher for stage 3. But we're at the Hope Summit, and there is hope, and we're trying to do better with reducing the risk of cancer recurrence. That's where medical oncologists are coming in. That's where we're talking about giving drug treatments to reduce the risk of cancer coming back. And so what I like to tell my patients is think of it like cleaning up after a storm, the storm being cancer, right? The storm passes, Dr. Ha has cleared the storm, but we still need to make sure that the debris that's left behind from the storm gets cleaned too. And that's where we think about medical treatments in early stage disease. So now let's talk about the lingo. What are the terms that loved ones and patients need to understand for early stage disease? So I made a table here, and this is all about the timing of treatment. So we have neo-adjuvant treatment. Neo-adjuvant treatment means treatment before surgery. The goal of this treatment is to shrink the tumor to help make the surgery easier for Dr. Ha and more effective by removing as much cancer as possible beforehand. Adjuvant means treatment after surgery, and that's to reduce the risk of the cancer coming back. And then there's a term called perioperative. Perioperative is treatment before and after surgery. And the goal of this treatment is to shrink the tumor before surgery and clean up any remaining cancer cells afterwards. I like to think of perioperative as the sandwich, right? Where you have surgery that's in the middle, and then you can have treatment before, neoadjuvant, and treatment after, adjuvant. The whole sandwich is called perioperative. So that was timing. What about responses to treatment? How do we as oncologists, as pathologists, see how well our treatment works? And so these are responses to treatment that's determined after a surgery is done, once the pathologist has the sample from the surgery, is able to look under the microscope and tell us how well did the tumor respond to treatment. So we have MPR, which means major pathologic response. That means that there's less than 10% of cancer remaining after neoadjuvant therapy. And then PCR, that's the goal that we're hoping for every patient, pathologic complete response. What that means is once the surgery happens, the pathologist looks under the microscope, they see no cancer cells are still alive after that neoadjuvant therapy. These are responses that we are hoping are predictors, very strong predictors of long-term survival for patients. We'll talk a little bit about molecular testing because it's so important. I'm a strong believer that every patient with non-small cell lung cancer needs to have molecular testing done. So why does molecular testing matter even for early stage disease? So before deciding on the best treatment, we test your tumor for molecular markers, or what we sometimes call biomarkers. My patients will come to me and you can hear molecular testing, you may hear biomarker testing, genetic testing, molecular profiling. Those are all synonyms for a very important testing process to really understand what's driving your cancer to grow. These tests are either done on your surgical sample, so after you have your surgery, or from that biopsy that first told you that you have cancer. Results can still take up to 3 to 4 weeks to come back for comprehensive next generation sequencing. Without these results, we might actually miss a more effective treatment or even a less toxic treatment. So really understanding these results is important to guide your treatment options. So why does it specifically matter? What do these molecular tests mean in early stage disease? So what are we looking for? We're really looking for the following characteristics here. So we have FDA-approved drugs already for patients who have early stage disease, who've had the tumor taken out, get molecular testing, and they're found to have, for example, an EGFR mutation or an ALK or ALK mutation. This helps us decide if targeted therapy is an option for patients after surgery. We're also looking at a protein marker called PD-L1, and that helps us guide the use of immunotherapy for patients in this setting. And then we're also looking for other mutations, BRAF, MET, KRAS, several other mutations. It's to help us understand if clinical trials might be an option for a patient, or if we have that information for future treatments if the cancer comes back, if it's needed. It gets us ready. We always want to have a plan B, a plan C ready for our patients. When we're thinking about your treatment plan specifically and how we build that, for most patients with early stage resectable non-small cell lung cancer, treatment is going to include surgery with someone like Dr. Ha, medical treatments like chemotherapy, targeted therapy, or immunotherapy. I made this meme about 2 years ago, right when the Barbie movie was coming out, and you guys probably remember this trio. Targeted therapy just stands out. It's the Ken of the trio. That's what we want to do for precision medicine for patients, right? And then monitoring and follow-up. That's a very key component of building a treatment plan for patients as well. The plan is going to be personalized, yes, based on your cancer stage, yes, based on the type of cancer you have, yes, based on the molecular testing, but just as important as these characteristics, and I strongly believe this, is your overall health and your overall patient goals. So make sure you're advocating for yourself about those components. That should be a conversation that happens with your oncology team. So this is a list of all of the FDA-approved regimens that we have now for resectable non-small cell lung cancer. In the red box, those are targeted therapies that are approved. Before 2020, if I was going to show you this slide, there would be one singular box, and that was chemotherapy, cisplatin chemotherapy. So this just shows you how quickly since 2020 things have changed, and it's because of patients like you. It's because of loved ones that supported their patients to get onto clinical trials. This is the reason why we have so many options that are available today. So thank all of you from the bottom of my heart, because really this is what progress is. This is what it means to be on trials and the impact that you can have. Monitoring after treatment is just as important as the treatments that you're getting, just as important as the surgery. So even after treatment ends, we stay closely involved in your case. So I recommend CT scans every 3 to 6 months, at least for the first 2 years, regular blood work and checkups with the team as well. Follow-ups and making sure that we're closely monitoring you is very important for catching any recurrence early. That's an opportunity to intervene. I know the slides are going to be circulated to all of you afterwards, but these are some questions that you may want to ask your team if you have early stage disease. So for the cancer details, what is the exact stage of my cancer? Has it spread to any lymph nodes or other areas? Is my cancer considered resectable, meaning can I go to surgery? Will genetic or molecular testing be done on my tumor? These are very important characteristics of the cancer itself. Surgery and treatment plan. What type of surgery is being recommended? And Dr. Ha and her team can very nicely talk you through that. What is the goal of surgery? What are the possible risks or complications? How might surgery affect my breathing or lung function afterwards? Why is surgery the best option for my type and stage of lung cancer? Do I need treatments before and or after surgery? And are there clinical trials? If your oncologist is not talking about clinical trials, if your surgeon is not talking about clinical trials, I encourage you, I empower you to please bring that conversation up. And then of course the surgical procedure and recovery, how long will the surgery take? How long am I going to be in the hospital? What kind of help will I need at home after surgery? And then follow-up and monitoring, as I mentioned, how often am I going to need follow-up scans and visits? What signs or symptoms do I need to watch for after surgery? Support, cancer care takes a village. So can I speak with a nurse navigator, social worker, or other support groups like Longevity, for example? Can I bring someone with me to my appointments? Who else is on my team? So in summary, early stage non-small cell lung cancer that can be surgically removed is called resectable disease, and it's often treatable with our goal for cure for patients. Treatment includes surgery and medications to reduce the risk of that cancer coming back, which is recurrence. Molecular and PD-L1 testing helps us personalize your care, helps us personalize your treatment plan, and you are not alone. Your team is here to guide you throughout every step of your journey. This is the Hope Summit. There is hope. I showed you the slide. Since 2020, we've had so many FDA approvals. There is a plan, and you have a team that's beside you. Thank you.
All right. Thank you for a wonderful talk. I'm going to make sure I know how to use this thing.
Just push the screen button right here.
Okay. All right. So good morning, everybody. My name is Ginny Ha. I'm a thoracic surgeon at Johns Hopkins, and I'm truly excited to be here and to be part of a session called Advances in Your Lung Cancer Care. I hope that we continue to have many more advances for decades to come, and I'm really happy and excited for everyone to be here together. So I'm going to talk to you a little bit about how surgery plays a role in the treatment of lung cancer. And we've had some advancements over the last few years. So when we talk about surgery in the space of lung cancer, there are three main groups of indications for surgery. Sometimes the cancer can be too advanced, and so we're using surgery to try to manage symptoms that can develop. At times, we may be dealing with an abnormal finding that's seen on a CAT scan, and surgery may be the only option of getting a diagnosis of this finding. But mostly we're going to focus on how surgery can be used to treat your lung cancer. And the overall goals of surgery is to really remove all known visible cancer, and then also do a thorough assessment of the surrounding lymph nodes in the area. And this allows us to, when we get the full pathology report back, to really know the true stage of the lung cancer. As Dr. Singh mentioned, the lymph nodes it can harbor microscopic cancer cells, and this allows us to get larger biopsies or chunks of the lymph nodes in whole and really rule out or rule in if there's cancer involved. So what are the types of surgery that can be done for the treatment of your lung cancer? And it varies. It's very individualized. It depends on multiple factors, which I'll go through. But the smallest resection that can be done for the treatment of lung cancer is something called a wedge resection, which is simply removing the tumor or the nodule with a small rim of normal tissue. The next step would be a segmental resection. And this is what we consider a better oncologic resection, where we're actually dividing the arteries and the vein and the airway to the smaller portion of the lung that harbors the tumor. It allows us to get a slightly larger margin and allows us to access some of the regional lymph nodes around the tumor. The standard of care for lung cancer for a long time had been lobectomy. And as you know, all of us are typically born with 5 lobes, 3 on the right side and 2 on the left side. And this allows us to do a resection of the tumor, get a really wide margin, and also assess the regional lymph nodes in the area. This usually takes or requires removal about anywhere from 15 to 25% of one's lung capacity. And as our keynote speaker had talked about in his personal history, pneumonectomy is one of the more radical surgeries that can be done. And this requires removal of an entire side of a lung. And it's really reserved for tumors that are quite large or quite central, and reserved for patients that have really great cardiopulmonary reserve. So how do we do these different types of surgeries? Before the advancements of surgical technique as well as anesthesia and the ability to do single lung ventilation, thoracotomy was the standard approach. This requires spreading of the ribs, cutting through several layers of muscle in the chest wall, and as you can imagine, it requires a much longer recovery in the order of several weeks, increased pain, and can lead to long-term functional disabilities. But with, I would say, some of the key drivers that allowed us to do more minimally invasive approaches have been advances of anesthesia, where we collapse one side of the lung that we're operating on in order to create space. And this allows us to use cameras and longer and smaller instruments to do the same type of resection. So a technique that's been around since the 80s and 90s, which is very analogous to laparoscopic surgery, is called video-assisted thoracoscopic surgery. This uses about 1 to 3 incisions, no spreading of the ribs, and we use a camera and fine instruments to do the surgery. This translates into less pain, quicker recovery, shorter hospital stay, and hopefully overall improved outcomes. And with the advent of robotic surgery, which I'm sure a lot of you have heard about, robotic surgery has really taken off in the space of thoracic surgery. This is very analogous to video-assisted thoracoscopic surgery and requires a slightly more number of incisions, but quite small in the order of 8 millimeters to about 1 centimeter. So 3 to 5 small incisions, again, no rib spreading. Also, shorter recovery, less pain, and a shorter hospital stay. But it allows us to accomplish the same types of surgery as we could do through a bigger incision. So when you meet with your surgical team, there are many things to consider in deciding what is the appropriate approach and type of surgery for the treatment of your lung cancer. When focusing on the tumor, we have to assess the size and the location, the type of tumor, the histology that's involved. Is it invading any other structures outside of the lung that require resection? And then in addition to the PET scan and some of the biopsies you may have gotten done, we have to also treat and resect the lymph nodes that may be involved or suspicious. We also have to do additional testing to make sure that surgery is a safe option for the individual. So some of the things that you might have heard of or gone through is something called pulmonary function testing. For a long time, we knew that majority of the patients that were diagnosed with lung cancer were often smokers, so their lung health were not as great. So when we're reducing lung function by doing surgery to remove the cancer, we can leave someone quite disabled, very breathless, and can really lead to major cardiac pulmonary dysfunction, actually. So we will require most patients to undergo pulmonary function testing to assess the health of your lungs. You may require some additional testing to assess the heart function too. We also get an idea of how functional one individual is. What are the kind of exercises that you do? Do you work full time? What are the things that you enjoy in terms of hobbies? And together with a thorough medical history, we can decide whether surgery is a great option for an individual. It's also important, some of these technologies I've talked about, especially robotic surgery, is becoming more widespread, but not always available around the world. Really, in the 2000s, robotic surgery was sort of developed, so the surgeons need additional training to understand and use this technology safely. But again, video assisted has been around for quite some time and has been also a standard of care. So understanding the institutional experience as well as the surgeon experience plays into this as well. We talked about sort of the stage is also very important. So if we're dealing with a very early stage lung cancer, there are additional options to consider. We can do more lung sparing surgery instead of doing a lobectomy, and I'll talk about that in a little more detail. And I'm having a hard time reading my slides. And of course, this is a decision that's made together. So with the patient, with the surgical team, understanding, what is the right approach. So we do have to factor in the willingness to accept certain complications and understanding the postoperative recovery and the resources you will need afterwards. So I talked about lobectomy, but I want to focus on sublobar resection since we've had a lot of exciting advancements within that and understanding what that means in terms of long-term lung cancer survival. So lobes are on the right side, right upper lobe, middle lobe, and lower lobe. On the left side, you have a left upper lobe and left lower lobe. But within a specific lobe, you have smaller anatomic subsections, which we call segments. And in the appropriate patients, we can consider doing a segmentectomy, so leaving majority of the lobe behind, which translates into better overall lung function and hopefully less complications. But within the definition of sublobar resections, you have two different types of resections that we use in the field of surgery, which is wedge resection, where you're not necessarily dissecting out the individual artery, the vein, and the airway to that segment, whereas a segmentectomy is a more involved procedure, and most surgeons would say that it's a better oncologic resection. But this, again, depends on all of those things I talked about in the previous slide. So lobectomy removes more lung tissue, typically in the order of close to 20 to 25% of your total lung capacity. It was deemed the standard of care for the treatment of early stage lung cancer since the 1990s. And it was thought with a larger resection, it probably will translate to decreased local recurrence rates. But the big question was, do we really have to take all this lung for a smaller tumor in the order of 2 centimeters? So there's been a lot of studies looking at this, and I'll talk about some of the two major trials that were just completed that has helped us to answer that question. So sublobar resection removes less lung, hopefully long-term translates into preserved breathing and lung function. And it's really reserved for small, peripherally located lung cancer that's early stage. But the trade-off is, if we're taking less lung, the margin is smaller, are the recurrence rates going to be higher? So we had 2 major trials that just completed, and really have to credit patients for getting this done, because without patient involvement and willingness to volunteer and help push these studies forward, we could never answer these questions. So one trial was the JCOC trial, which is centered in Japan, and the CLGB trial were run by surgeons in the United States. And they wanted to answer the question, do we have to do a lobectomy, or doing a sublobar resection, is that not only safe, does it preserve lung function, and does it translate into equivalent oncologic outcomes? And so what they found that there was no difference whether you had a lobectomy or sublobar resection. The oncologic outcomes were actually very similar. So there were not increased recurrence rates that we were very fearful of. They did find that lung function long-term was actually better in the sublobar group, which is intuitive. So these are very encouraging results. So in the last actually few years, we're starting to see more surgeons going for a sublobar resection, hopefully. We know that patients that have lung cancer are at increased risk for developing second cancers down the road, but with more lung function, you may be a candidate, if you were to have recurrence, to have not only another resection, but you'd be healthy enough to get any additional treatments that are required down the road. So hopefully this translates into overall longer survival. So what does this overall mean? You can't do this for every type of tumor. It's really reserved for tumors that are less than 2 centimeters and are peripherally located, and for early stage lung cancer. So you may not need a whole lobe removed for your lung cancer. When you preserve lung function, it does translate into decreased postoperative complication, mainly respiratory complications, things like pneumonia or needing oxygen, or breathlessness after surgery. That reduces your quality of life. It means you can have faster recovery, and hopefully overall long-term survival, and live a fuller life after resection. So what are some of the things that you can do to prepare for surgery? And so preparing for surgery, optimizing an individual's quality before going to surgery translates into better outcomes. So I'm going to talk a little bit about what prehabilitation is. You may or may have not heard of this. Not every center has a formal prehab program, but it's something that starts before surgery or before treatment. And the goal is to help support and boost your physical and mental health and nutrition before undergoing treatment or surgery, and hopefully translates to better outcome. And there are many different studies. Prehab comes in many different forms. This is not only reserved for cancer surgery, for all types of elective surgery, and there's a lot of data that shows that this is a good thing to have. The benefits are you tolerate the stress of surgery better, hopefully have a faster recovery, and the mental aspect of it is better outlook during your treatment, which can be very difficult. So what are the main components of prehabilitation? I've broken it down. So exercise is a really key component, focusing on aerobic, resistance, flexibility, balance and training, and particularly in lung surgery, inspiratory muscle training, and that can come in many different forms. It usually involves the expertise of physical therapy to help with this. In lung cancer especially, but also in many other types of surgeries, we do encourage and incorporate a program for smoking cessation, because short term, it not only translates into less post-op complications, but long terms can help with the overall health of the patient. Nutrition counseling is extremely important. Particularly in the setting of someone that's malnourished or someone that has decreased muscle mass. We know that individuals like these will have increased risk for complications after surgery. In patients who are diabetics, it's extremely important to have blood sugar control before going in, and it reduces things like infections postoperatively. And as you know, that having a diagnosis of cancer is extremely difficult. It's a huge mental load, and so providing psychological support, whether through a mental health professional or through peer support, is provided. And respiratory therapy is also a key component of this. So this is a busy slide, so this is a lesson in how not to do a PowerPoint presentation, but I wanted to summarize. You know, there are many different types of lung cancer surgery that are done, and the approaches are also different. And this requires factoring in many different components to decide what is the best approach for you. There's new data that suggests that you don't have to do a lobectomy. It's no longer the standard of care for early stage small peripheral lung cancers. And prehabilitation can really have a huge impact on your journey throughout your cancer treatments, particularly surgery. So thank you for your time. Thank you for inviting me.
Oh, hello everyone. I'm going to moderate your questions. Colette Smith here from the Bronx. I am a 10-year lung cancer survivor, and I'm living with an upper left lobectomy, and we have quite a few questions. Someone says, I'm newly diagnosed, and I want to know how I may best educate myself besides Dr. Google.
Yeah, well, I can start. I mean, I think the support groups are huge. So Longevity has great information for patients that are newly diagnosed. Reaching out to your cancer center as well. I'm focused on patient education research myself and trying to build these materials for patients, integrate it. I've come up with a list of questions as well that patients should ask at their first medical oncology visit. I'm sure Dr. Ha can maybe speak to some of the surgical resources, but there's amazing support groups. Ask your cancer center, ask your oncology team.
Yeah, and there's many, like the American Lung Cancer Society or the NCCN websites also have great resources outside of Google that can talk about the standard of care.
Thank you for that. Dr. Singhi, you described a process called a sandwich as far as treatment. What role does molecular testing and precision medicine, how does it fit into that sandwich?
Yeah, so the sandwich that I showed on that slide is what we call perioperative therapy. So surgery's in the middle, and then we have the top bun, which is treatment right before surgery with medical drugs, and then treatment after surgery. And so you get this sandwich approach of having some treatment before surgery and some treatment after surgery. There's been FDA approvals for that very strategy with chemotherapy and immunotherapy. What we're trying to understand as a community is how much should we push for patients after they're done with surgery to continue to get some type of systemic therapy, to continue to get some type of drugs after they've gone through a surgery. That's the big question. We don't have a trial right now where we have compared in large numbers patients that just got treatment before surgery and then patients that got that sandwich approach of before and after. So we really have to use shared decision making. We have to look at how well did the tumor respond to some treatments before surgery. We have to look at the molecular testing that I mentioned. So it's a multifactorial shared decision making process, but you need all the components, including what the patient goals are. So I have some patients that say, I want to be as aggressive as possible. I want to really make sure that if there's any cancer cells left behind, I want to do it, right? And then I have some patients that have gone through surgery. They unfortunately had a longer recovery period. They really struggled to get through surgery, and they struggled to get through some of the treatments before, and they say, I'm done. I don't want to do it. That matters just as much as the molecular testing, just as much as these different approaches. So I would say in a short answer, it really depends, and you have to have that whole conversation.
Okay. Do you have anything to add to that, Dr. Ha?
No, I agree. I think now that as a surgeon and seeing so many advancements in the medical oncology systemic therapy space, I often have to speak with my medical oncologist. No longer is a thoracic surgeon kind of standalone anymore. It's increasingly become a multidisciplinary approach to lung cancer in the early stage lung cancer, which is somewhat newer for us because it used to be surgery or radiation alone. So it's exciting. And I learn a lot from my medical oncology colleagues. So there's, not just one pathway anymore. I mean, there's so many, and it's become hyper individualized and personalized, which is a good thing.
Okay, thank you for that. What is a bronchoscopy, and what role does a bronchoscopy play in diagnosing a patient?
Yeah, so sorry I didn't touch upon that, but bronchoscopy is usually an outpatient procedure, but it's analogous to a colonoscopy, if some of you have had. You don't have to do any of the bowel prep except, which is a good thing. But it's a small camera that's inserted through your throat into the airway, so into the windpipe, and it navigates throughout the lung, through the airways. Sometimes it's needed, or it's an approach that's used to diagnose whether lymph nodes in the area are involved, or to get to a suspicious lung nodule and actually get biopsy and tissues from that approach. So that may be the initial approach and way one gets diagnosed and staged.
Okay, thank you for that. And what are lymph nodes, and what role do lymph nodes play in diagnosing and staging?
So lymph nodes are just little organs throughout your body, and around the lung tissue. It really, understanding whether lymph nodes are involved or not helps us to clarify the stage. Because if we suspect that there's cancer cells outside of the primary tumor and has spread to these little stations of lymph nodes around it, that means that the stage is typically higher. Is there anything else you want to add?
Yeah, the way I explain lymph nodes to patients, I talk about these roadmaps, these networks that all patients have, right? So cancer is very smart. It learns in your body how to move around, and there's really two routes. There's the blood, right, where the cancer cells can move through, and then there's lymph nodes, which are these networks of connections. Everybody's got lymph nodes. They swell up, they're activated when you're fighting infection, but they're channels, they're ways that the cancer cells can move. And so a really common pit stop for lung cancer is lymph nodes that are around the airways and lymph nodes that are in the middle of the chest. And so it's really important because our imaging can fool us. So we'll look at imaging sometimes and we won't really appreciate that there's lymph nodes that are involved, that the cancer has moved from the lung to lymph nodes near the airways or the chest. And so that's where a bronchoscopy is really important, where they have to go in, a pulmonologist will go in, they'll actually take a look, and we're surprised. On imaging, we didn't see any concerning lymph nodes, but when they're actually in there, they do see some, and they'll biopsy it and they'll sample it. So that's generally how I explain lymph nodes and why it's so important to make sure we understand the staging.
Okay, perfect. This is a specific question regarding staging. Someone was diagnosed 10 years earlier. Congratulations to that person. And they never had biomarker testing, and it appears as if the cancer has returned. What are some treatment options, and how can that person possibly get a biomarker tested?
Yeah, so they absolutely should get biomarker testing. If there's concern, unfortunately, that the cancer has come back, I'm really sorry to hear that it's been 10 years and now there's this concern. They should absolutely go get a biopsy. And once the biopsy's done from the tissue, they should talk to their oncologist about getting full, comprehensive molecular testing. What does that mean? So you don't want to just look at a few different mutations. Sometimes there's these limited panels, and they're only looking at a few mutations like EGFR and ALK. That shouldn't be the case anymore. I strongly believe that patients need comprehensive testing. So we're looking at several different mutations, not just from the DNA perspective, but the RNA perspective. So you need to be looking for both testing methods. So yes, I would say go get a biopsy and ask the oncologist to get comprehensive molecular testing.
Okay, thank you for that, Dr. Singhi. And a follow-up question to that. Are targeted therapies only for stage 4 cancers?
No, not anymore. It's really exciting to be able to say that. So the slide I showed you, that's a slide that's updated from 2020. So again, if I did this talk 2019, even early 2020, and I was showing you all the therapies that we have available for early stage disease, there would be one, and it was just chemotherapy, cisplatin chemotherapy, that's it. Now I'm showing you chemotherapy, immunotherapy, targeted therapies. That's just FDA-approved drugs. I myself have many patients. I particularly specialize in seeing patients who are 50 and younger, so young onset lung cancer. Many of these patients have mutations, and they qualify for clinical trials where we're looking to see, can targeted therapies like osimertinib and other therapies like that, can patients who have early stage disease, stage 1, stage 2, stage 3, can they also benefit from targeted therapy? And spoiler alert, yes, we're seeing the benefit. So yes, targeted therapies are absolutely an option for patients with early stage disease.
Perfect. Thank you for that. Now, what specifically defines no evidence of disease? Like, what are the things that physicians look for?
Go first.
Yeah. I mean, I think you'll talk to some of the newer things that are available, but typically, say in a truly stage 1 person that I'm following, if it's a higher stage, usually I'm following together with other specialties, but looking at imaging, that's why you're getting CAT scans very regularly, making sure that we evaluate any new symptoms that you've developed. So those are some of the things that I look at from a standard approach, but I think there are other things that are coming down the pipeline that will help.
Yeah, so right now, standard of care, for me to be able to tell a patient, I get very excited when I get to say no evidence of disease, NED, right? So again, our goal for treatment for patients with early stage disease is cure. To be able to tell patients you have no evidence of active cancer, no evidence of disease, NED. The way we do it is, yes, we're talking to the patients about symptoms, right? We're doing our physical exams, we're meeting you, but then we're also looking at your scans. Our scans are only as good as the level of detail of scans, right? So we're trying to do better to understand truly are patients no evidence of disease. And so some of you may have heard about these liquid biopsies, these blood tests, which look for ctDNA, which means circulating tumor DNA. Small amounts of the cancer cells and their DNA can spill into a patient's blood. Right now, we don't have the best sensitivity of those tests to truly be able to tell someone that there's no evidence of disease, that there's no cancer from a routine blood test. I think we're getting there. I'm hopeful in about maybe the next 5-10 years we can start to say that, but we're not routinely there yet. So I would say if you're looking for a blood test to tell you no evidence of disease, I would do it on clinical trial, but routinely we're not doing that yet.
Perfect. Thank you for that. And I have another question here. What is the difference between DNA and RNA testing?
Yeah. So we're trying to understand what we call molecular testing and what it means to be comprehensive, to really make sure we are looking for what we call actionable genomic alterations. These are changes in the cells of the lung cancer itself. So when we're looking at lung cancer for mutation testing, we're really focusing on the changes in the tumor cells, not changes in the rest of your body cells for the most part. And we used to look at just DNA, right? Everybody has DNA, your cells all have DNA. That's the genetic makeup that teaches your body how to make proteins that are functional and carry a lot of normal processes. But we also now have realized that if we're just looking at DNA, we're missing some of these mutations. And so you have to look at another component called RNA. RNA helps us look at different fusions. So you may have heard of a fusion protein like ALK or ALK. That one we can find, yes, on different conventional methods, but there are some other more nuanced mutations, nuanced actionable genomic alterations that we may miss if we don't look at an RNA component. So what I tell patients and what I make all my trainees do when they're in clinic with me is if I get a second opinion or third opinion and I read the oncologist note and it says, no actionable alterations, no mutations, I say, show me the report. Because I need to really make sure that they didn't just look at DNA, they looked at RNA as well, and really give the patient the best chance to say they don't have a mutation. So it's very nuanced in summary, but looking and asking your team, did I get DNA testing and RNA testing is key.
Okay, thank you for that. And for someone who's been diagnosed in a later stage, this is a surgery question, how is surgery generally something that's a best practice with a later stage diagnosis? If why or why not?
So in general, surgery is heavily utilized in early stage, especially stage 1. Surgery conventionally has been part of treatment plans and standard of care up to stage 3. But stage 4 cancer, we typically would not offer surgery, and that's where we're using surgery usually for the management of symptoms with advanced cancer or diagnosing multiple spots that are suspicious. But I have to say, with the advancements in sort of the systemic therapies that are now available, and especially in patients who are very young, otherwise very fit and healthy, we are seeing that all this disease has really shrunken down and maybe there's one spot left, and that's where surgery may be used in this setting. We're understanding really if that is effective and a meaningful way of treating things. But yes, increasingly in the last couple of years, I am operating with sort of a pseudo-curative intent in patients that have really advanced disease.
Okay, Thank you for that. We have one last question because we're getting close to time. Can you talk to us some more about oligometastasis, locally advanced non-small cell lung cancer in stage 4? Very precise.
Oh, yeah.
Yeah, please.
So when we talk about, not all stage 4 disease is the same. I think that's really important. So you may have heard this term oligometastatic disease. That means a few sites. Oligo means few. There's a few sites of disease outside of the lung. How do we define few? Is it 5 sites? Is it 3 sites? We as a community are trying to understand that, but that's what oligo means. Then there's polymetastatic disease. Poly means that there's a lot of sites of disease outside of the lung, right? More than 3, more than 5. And so the question here is, if a patient has just a few sites outside of the lung, yes, they're stage 4, but is there a role for things like surgery or radiation? My answer is yes, I do believe that. I see a lot of patients that are young. Many of these patients do have mutations like ALK, ROS1, EGFR. And like Dr. Ha said, our therapies are getting better for patients. Patients are living longer. They're having a dramatic response to the tumor that's in the lung, but also in sites outside of the lung. And so the question becomes, can we boost that response outside of the lung? Can we help clean up other spots? And I've seen it, yes. So I think having a conversation with your team, if you have oligometastatic disease, is a very reasonable opportunity, and every case is different, but it's reasonable to have that conversation. Dr. Ha, do you agree?
Yeah, I mean, I think this speaks to the fact that multidisciplinary care is very important, and so going to a place that already has that in place, I think is really helpful for patients because it's no longer one recipe for everyone. It's really individualized.
Thank you very much, both Dr. Ha and Dr. Singhi, for your time
It's our pleasure.
here with us.
Thank
And
you.
everyone, let's show them some love.